uh, on the topic of wound complications in renal transplantation. Dr. Tariq Cachalia, who's our current transplant fellow at RPA Hospital in Sydney, has kindly agreed to give the presentation, and I'm sure you'll all enjoy his work. If you could hold any questions or debate to the end, then I'm sure we'll have lots of things we can work through. So, Tariq, if we wouldn't mind, you could please go ahead.
Sure. Thanks. All right. So, just an overview. We can talk about some of the complications, which sort of everyone I'm sure knows about, and the risk factors, and then some strategies for prevention and management. Overall, these are high-risk patients resulting in a high incidence of wound-related complications. Typically, you have a patient that sort of looks like that one there on the right-hand side with a big oblique incision in 20 to 40 centimeters, with larger wounds more at risk of complication. But we do need to make sure that we, recognize the point of the operation is to perform a safe transplant. So, you need a wound that's sizable enough to allow you adequate exposure to perform the operation you need to perform. Wound complications, although they often don't sort of result in major issues with graft loss, they do have other consequences, and their prevention and management is therefore important. The incidence of wound complications overall, they're the most common surgical complication in transplantation, and they're becoming more and more significant as people must sort of notice that the broadening of criteria for who gets a transplant, makes them more significant. Obesity is a major risk factor and something that we'll sort of touch on a bit throughout the talk. And as I said, it usually doesn't affect graft function, but can affect morbidity, quality of life, and also health costs. And the wound complications are multifactorial. The main complications you see, the early ones are surgical site infections. There are fluid collections, such as lymphoceles, as well as superficial or deep wound dehiscence. And so the later complications are things like incisional hernias, which are very common in this group as well. Starting just with surgical site infections, so they're defined being usually 30 days post-operatively. The infections that can either be superficial, deep, or surrounding the transplanted organ. They're about 4% incidence, and the prognosis usually with sort of treatment of antibiotics and other things is usually quite good, and they tend to occur early within the course after transplant. The most common organisms tend to be gram-negative organisms like Pseudomonas and E. coli, with gram-positives like staph or skin bugs and fungal infections less common. But definitely the incidence has improved with antibiotic prophylaxis, and there's clearly some role with the gram-negative involvement of urinary contamination of the surgical field being possibly a culprit for why we get some of these gram-negative wound infections. There are lots of risk factors, as we mentioned, for getting wound infections, and it also predisposes you to further problems like dehiscence and incisional hernia. Incisional hernia is another sort of significant problem in transplantation, and it's an incidence of about up to 7%. Usually occurs within the first 3 months post-operatively, and there are lots of recognised risk factors again, obesity, coexisting hernias, if patients have had multiple surgeries and also did a longer surgery, and then complications related to surgery. The use of sirolimus mTOR inhibitors also affects the risk of incisional hernia. And there are some things that are sort of not 100% related, but sort of in some studies show that it might correlate to hernia risk, female sex, type and dosing of immunosuppressants, especially things. There's a bit of a debate about mycophenolate and its role in hernia occurrence, and also the specific technique of abdominal wall closure and also the incision that you choose to make also will affect the risk of hernia. Seroma or lymphocele is often a later complication, but can occur early as well, and its incidence is quite high, up to 50%. Most are found incidentally and don't have any sort of major functional complication, but they may cause symptoms of general symptoms such as pain and swelling. They may affect the vasculature of the lower limb, as well as the function of the kidney. They can also become secondarily infected. So preventing wound complications, just starting from the beginning, I guess patient selection is an important thing. We sort of the recognised risk factors for wound complications, they're very well known. But individual, units determine who is eligible for transplantation, and there's a trend over recent years to expand the eligibility criteria, because we realise that even in older patients and obese patients, they have a significant benefit of receiving a transplant compared to spending time on dialysis. Obesity has a significant effect on kidney transplant outcomes, and it's been shown to increase wound complications, there's a reduced overall survival and also graft survival. And, for us, when you see that person on the table, it does make you realize that it's going to be a challenging few hours for you. The transplants, as I said, still provide survival benefit for these patients. In terms of cutoffs, a lot of places have gone away from a definite cutoff for a BMI cutoff for transplant. But, overall, we'd say definitely over 40, you really need to think about what's happening. And some places have a more strict cutoff. And the conventional weight loss strategies that we implement or encourage patients to do, as we all know, are challenging, and especially for patients who spend 3 days a week on dialysis, I think it becomes even more challenging for them to lose weight. This is just a little summary of showing that even in patients with high BMIs, there is improvement with a transplant. You can see the curves are slightly different for the higher BMI patients, but overall they still benefit from transplantation. So it's not that they should be excluded, but maybe things need to be optimized to improve their outcomes. We all know that bariatric surgery is efficacious in treating obesity in the general population, and it's the most effective method of weight loss and preventing and treating some of the complications related to obesity. But the use in the kidney disease population is and transplant population is a little bit less certain. It has been shown to be safe in patients with end-stage kidney disease on dialysis, and it does lead to sustained weight loss and also improved comorbidities. And there are some studies about the use of bariatric surgery in kidney transplant patients, either pre-transplant or post-transplant. And generally it's thought to be safe, but some of the other outcomes are a bit less certain. The absolute BMI cutoff, for who should be referred for bariatric surgery, which type, whether it's a sleeve or a Roux-en-Y gastric bypass, and also the timing of surgery. There's some talk of whether you perform a bariatric surgery pre-transplant or after their transplant, and this can be determined by various things, including the availability of bariatric surgery, how long people are spending on the waiting list, the complications they have related to their obesity. So some of these things are still a little bit uncertain, but overall, I think there'll be emerging use of bariatric surgery to either help patients get on to become eligible for transplant or help them get through the process a bit better. Minimally invasive surgery is another thing that's sort of becoming, I guess, a bit more talked about, and especially in the setting of wound complications. We know these patients are high risk and have high wound complications, and overall minimally invasive surgery, it can be used to reduce complications, reduce costs, such as length of stay in hospital, less wound management devices, less re-interventions, and also increased access to transplant for obese patients. There are some challenges using minimally invasive approaches for transplantation, including prolonged anastomotic time, prolonged warm ischemic time, the training process to be able to do these procedures, and also the cost and availability. Laparoscopy has never really been used much in transplant due to the technical challenges, but I think with the emergence of robotic assisted surgery, it's something that could make minimally invasive surgery more feasible because of the increased sort of technical skill that you can have. The first reported sort of minimally invasive robotic transplant was in 2010, and there hasn't been, I think, a lot of progress in this area since then. But overall, the data suggests that it's a safe and comparable to open surgery, as long as it's an experienced transplant surgeon as well as an experienced robotic surgeon. It does show in this sort of more recent meta-analysis from earlier this year that there is a reduction in wound complications, less post-operative pain, and possibly a shorter hospital stay, but there's no sort of impaired graft function, and overall survival was similar. The learning curve and availability of somebody to teach you, as well as a robotic device, is obviously another issue. Going into sort of intraoperative things, prophylactic antibiotics is something that's very important. The best regime is also sort of not 100% certain, and I think we use a cefazolin regime at RPA. I'm not sure what regimes are used in other centres, and with them sort of high prevalence of sort of gram-negative wound infections, whether there's a need for sort of more gram-negative cover. And there's no, at this stage, routine use of post-operative antibiotics except for their sort of the prophylactic things like Bactrim, but that's something else to think about. The incision that people use, I know at RPA, it's a predominantly Gibson incision-led service, with one surgeon performing a lower midline approach to be able to access the retroperitoneum. There's been sort of, I think, multiple different ways to access the retroperitoneum, with the Gibson incision generally showing sort of, I guess, the best results. The lower midline incision has been sort of recently sort of reviewed at RPA Hospital, and it did appear even in patients with sort of more comorbidities that there was no increase in complications, and so it's definitely a thought. I mean, it just, I guess, from our experience, it does seem to heal quite well. The wound often tends to be a bit smaller, and the patients do seem to have a bit less post-operative pain from the lower midline incision. And it can be used, in patients who've had sort of previous lateral surgery, and also who are a bit on the bigger side. Preventing lymphoceles, including surgical technique to reduce that risk, with limiting your lymphatic dissection, careful ligation of lymphatic channels, whether people use an energy device like a ligature, or whether people use just simple ties and for ligating lymphatic vessels. I think it's an important part of the surgery to reduce the fluid loss. Drain use is another interesting thing that we don't routinely use at RPA, but there was a survey a couple of years ago performed which showed in Australia and New Zealand 60% of surgeons reported routine use of drains, which are inserted into the retroperitoneum around the kidney, either one or two drains. The rationale that was reported in that questionnaire was mostly they were worried about bleeding risk. So patients who were on antiplatelet agents or anticoagulation, patients with sort of multiple comorbidities, really obese patients who they were mostly worried about bleeding, or it was just part of their routine practice. So it was interesting that there was quite a large number that used drains routinely. The actual evidence for use of drains is lacking. There was a systematic review performed looking at its effect on wound complications, and found that it didn't really reduce wound complications, although it did, as expected, reduce fluid complications. And there's also a bit of uncertainty about the use of a drain for, say, 2 or 3 days post-operatively, or even a bit longer, when a lot of the lymphocele presentations are often weeks to sort of months down the track. And also whether there's having a bit of fluid around the kidney is of any clinical consequence. So drain use is again something that I'm sure is sort of up for debate. The closure technique of the fascia, again, no particularly sort of strong evidence as to which way is best. Having a good tension-free repair, like any fascial closure, is important. The sort of stitch trial, small bites of the midline closure hasn't really been shown to sort of reduce the risk of hernia in lateral incisions. And whether you close in a single or double layer is also up for debate. There was, I think one study thought that single layer had a slightly higher risk of incisional hernia compared to a double layer fascial closure. Also, patients who have sort of kidneys large for their size, where there's a risk of a compartment syndrome and, with a very tight fascial closure, there is some talk of using an inlay mesh in those patients. But generally that's, thought to be high risk in a patient who's about to be immunosuppressed and who has, might need access for biopsies, things like that. So fascial closure is, again, another area where there's not a definite wrong or right answer. Negative pressure wound therapy is something we've been using for most of our high-risk patients over the last year or two, where we use a Provena dressing on the closed surgical wound. And we think that it's useful for the high-risk patients, which sort of most of our patients are. And we usually leave the dressings on for about a week, essentially until the battery on the device runs out. And that sort of has shown, relatively good results. But there's no sort of, again, there's not a lot of evidence in the transplant setting for the use of this, and it is costly. There has been, shown this is sort of in studies looking at other surgery, including, orthopedic surgery with hip and knee replacements, sternotomies, cesarean sections, those sorts of wounds. That those dressings are useful for reducing infection, seroma, and exudate compared to conventional dressings, but there's no sort of good evidence in transplant. And managing sort of wound complications. I mean, most of this stuff, I'm sure people are pretty good at managing these wounds. We have sort of standard principles of managing an infected wound, with obviously confirming the diagnosis. And imaging is often useful to sort of exclude any other deeper complication, like a deep dehiscence or a problem with the graft itself. Assess for organisms with early swabs, and then starting empirical antibiotics, which are then guided by the cultures. The usual process of draining and debriding, and that can either be radiologically draining at the bedside, or taking a patient to theatre for a formal washout. And then it's pretty standard to use an application of negative pressure dressings thereafter, and that can be for a variable amount of time to either allow a delayed primary closure or a secondary closure. And it may take a number of months to fully heal. If there's a fascial dehiscence present at the time of finding an infected wound, it becomes a more difficult situation. There was a few case reports written recently about the use of a non-absorbable mesh in the setting of an infected wound with early negative pressure therapy, which found that there was good healing and no sort of complications or sort of prolonged wound infection and good abdominal closure. But again, I think this is another area that's interesting in patients with a high risk of fascial dehiscence and herniation, on immunosuppression. How you get a difficult abdominal wall closed in this setting, I think, is an interesting area. And this is kind of, typical, I guess, transplant patient, that big guy, and then they might have some wound, superficial or deep dehiscence, managed with a vac dressing, and then it slowly heals via secondary intention over many months, and hopefully with a good result at the end of it. Incisional hernias, as we said, are pretty common, and usually when they are detected, surgery is usually indicated, because often these patients will fail non-operative management. Repair, it can be challenging due to the patient factors, body habitus, also the presence of the graft and nearby bony prominences, as well as the fact that they're on various immunosuppression. I think the sort of standard is probably an open mesh repair for these patients, but these still have a relatively high incidence of recurrence, and there are some complications related to the mesh in a patient on immunosuppression, and it can impair the access you have to the kidney for biopsies and further surgery. The mesh positioning is also a bit uncertain, whether to mostly an onlay mesh is generally frowned upon, I guess, because of the risk of infection from skin, from skin infection and superficial infection, with either a sublay or a retromuscular approach thought to be probably better. And laparoscopic hernia repair is probably being increasingly used. I haven't seen many of these done with us, but they are useful because it allows, often the patients don't have significant adhesions because they're immunosuppression. It allows you to visualize the defect and repair it and make sure the mesh is well away from the skin, and you sort of reduce the risk of, I think, injuring the kidney itself. But it does have a risk of complications related to bowel injury, bladder injury, things like that need to be considered, and the recurrence rate, is probably slightly less than the open repair approach. Fluid collections like lymphoceles, again, can be challenging to manage, but I think determining which ones are clinically significant is important. The treatment options, again, are sort of percutaneous approaches like aspiration, insertion of a drain, and then sclerotherapy with things like iodine being sort of flushed into the cavity. Surgical management is obviously an important part of it as well. Usually if patients fail, percutaneous management and laparoscopic and open are obviously two approaches there. And the factors, determining the management are based on this type of symptoms the patient has, the size and location, as well as, the effect on the kidney. There was a review a few years ago, which thought that laparoscopy was probably the best way to treat a lymphocele with sort of fenestration and drainage into the peritoneum, and found that it had a very low recurrence rate and a relatively low complication rate, but 10 to 14% can still be significant. Aspiration has a very high recurrence rate, and open surgery has slightly more complications for the patient. So that was all, and then I think Dr. Lawrence was going to have some
great talk
discussion.
Thank you so much for all of that. You've covered all the clinically relevant topics. I guess the one thing I would ask you, and then ask for the consultants online just to comment about, was whether, clearly being obese is a risk factor for developing wound-related complications. Do you think that reversing obesity will ameliorate that risk? In other words, if you take formerly obese people, do you think they have a lower risk of wound complications? Because I think that's really the critical question in terms of figuring out what to do with these patients.
Yeah, difficult to know. I'm not sure. You'd think that making your operation a bit easier, so it would take a bit less time, having an easier approach, making a smaller incision, all those things maybe would make overall your complications a bit less. But I don't think that's what the evidence shows at this stage. So
the reason I ask is no one's ever demonstrated that that formerly obese people have a risk of complications similar to the never obese, and so I think that's always concerned me about putting patients through bariatric surgery, which has got its own risks and complications, without really knowing that it's going to be beneficial per se. And I can say that some of my worst wound complications have arisen in people who were formerly obese. Particularly the worst ones are people who were formerly obese and then had abdominoplasty procedures. They're very much at risk of wound complications.
Could I make a comment, Jerome and Tariq? Very good talk. It's all sorts of issues that we hate to see, and it's always depressing when you see it in your own sort of procedures. But I would agree that I only refer for bariatric surgery when they are not transplantable purely because of their obesity. I don't consider bariatric surgery for a renal failure patient just because I want to reduce my wound complication, because I suspect, as Jerome alluded to, it probably doesn't. They often end up with quite a floppy pannus, and it's a horrible wound that falls apart. But patients with a BMI of over 30 do just as well. It's the malnourished, the BMI less than 18, that do significantly worse in terms of patient survival. So we're trading dialysis for wound dressings often, aren't we, with those obese patients? But I think bariatric surgery should really only be for the ones that cannot be transplanted with their current build. That's a great indication for bariatrics. That's my feeling anyway. And just one other take, Tariq, on that lovely paper by Anya Lukowitz, who I was hoping was going to become a surgeon, but she saw sense and I think became a physician. She surprisingly showed, and she changed our management after that review, because simple aspiration had a 25% success rate. So again, it's looking at maths in a different way. Sure, it had a very high recurrence rate, but actually there was a 1 in 4 chance that that lymphocyte needed no other intervention after a simple aspiration, which we were amazed about. And it's obviously large numbers at the time. You could probably do that systematic review again because it's over 10 years now, but it really changed our management. So we would pretty much have never used aspiration. Now we always use it as our first line, and then we would use it for management of a recurrent lymphocyte after laparoscopic drainage. So sure, it has a high recurrence rate, but it also surprisingly had a 1 in 4 chance of success. So it depends which way you look at it. But that was just my comment on your talk, really, was that lymphocyte fact.
Thanks, Henry. I think we're very privileged to have probably one of the very few people in the world who's ever done a laparoscopic kidney transplant online in forms of Bulangi. And I just wonder if Bulang wouldn't mind commenting about how he feels, what place minimally invasive kidney transplant may have in the future for these patients.
Thank you, Jerome. That's a really challenging question. I did one case which, when we had the first patient selection, we actually do not choose, obese patient. Actually, the patient well built, with BMI probably about 23, 25. Actually, that case, he's doing really well. There's no any surgical wound complication with only 7 centimeters scar, just like a financial incision. But I think there's a role. Recently, I saw another laparoscopic kidney transplant report from Argentina. Seems some people also started trying. With the instrument involving better instrument available with articulated laparoscopic instrument, this probably can be revisited to look at the possibility for laparoscopic. But however, robotic really take in place the good data from Chicago University by looking at obese patients that use robotic kidney transplant significantly reduce wound infection rate. That paper very very reassuring for the role of robotic surgery in kidney transplant. Some kind of a downside in terms of if you needed to do kidney biopsy down the line. I think that's a part of the challenge in terms of the follow-up. As well as the robotic really have the role for the future, in particular when we try to expanding kidney transplant for obese patients. And absolutely, as Henry mentioned, whether obese patient you needed to do bariatric surgery or not, basically depends. I think the patient body habitus, whether you can approach for transplant, even a relatively longer incision, how to minimize wound infection or complications, for the relatively obese patient, not extreme, but I personally feel you put a second, subcutaneous drainage, that will minimize the collection risk of the subcutaneous layer, which could potentially reduce the infection and subsequent, wound complication. That's just my personal thought and how I do in clinic. In terms of other management, like lymph cell, I probably personally haven't done lymph cell financing for a long time because most lymph cell can be just percutaneous, put a pigtail drain, get a resolve, take 4-6 weeks. Usually the drop by itself. I think laparoscopic surgery for lymph cell is easy to deal with, superior to the kidney graft lymph cell if occurred at that point. But I found it relatively challenging if the lymph cell occurred at the inferior area of the kidney graft, like between bladder, ureter, and renal hilum. That's the area I feel quite a challenge. Particularly this lymph cell collection will cause some pressure to the iliac vessels or ureter, which really require clinical management. But I feel percutaneous is a much safer way to deal with rather than laparoscopic surgery, because other area we need to try to do laparoscopically. The tissue relatively thick, from intraperitoneal area approach, very difficult to visualize where you can make the window, and a higher risk to injury like ureter, and also the risk of the vessel injury as well. So that's my personal experience. Most of the time, I just put a interventional radiology nowadays is really good. They just put a drainage by ultrasound guidance. Sometimes I use the CT, and most of the time, up to 4-6 weeks, it will drop by itself and without further intervention. Really, another thing is really congratulate Jerome and Tariq. It's a really very good topic and very practical, you can say, and a good comprehensive review, and also share your unique experience. That's great. Thank you very much.
No problem. Thank you.
Thanks, Willan, for your generous comments. I think the one thing I would end with is, you know, the data from Ahmedabad. There's an Indian group who very, very carefully analyzed the learning curve for robotic kidney transplantation, and it's clear from that if you are not simultaneously a experienced robotic surgeon, which in our context basically means a urologist, and an experienced kidney transplant surgeon, then the learning curve is very long. And so I think it's unlikely that in the current Australian context, there'll be many more than a handful of people in Australia who could ever take that on. That certainly doesn't include me. And it's not a procedure where you can learn robotic surgery. So, you know, you'd have to imagine some other sort of surgical practice that could lead you into that.
Yeah,
so I think that's one really important thing to bear in mind.
I totally agree. I think you know, in Australia context, seems a urologist, if a urologist is a kidney transplant surgeon as well, and this urologist will be in the best position to do robotic kidney transplant, because most of the urologists in Australia now that do robotic radical prostatectomy, which involve, you know, the blood neck urethral anastomosis, that got that opportunity to, you know, polish that technique. And if this urologist is also doing kidney transplant, like you know, like Howard, you know, he will be the best person in place to do robotic kidney transplant. Yeah, but you know, with the technical involvement, I think, you know, one day we'll probably be able to learn something, particularly for the young generation, to pick up this technique. I think for the normal build, or relatively, you know, normally we accept for kidney transplant, probably I don't think there's much role for robotic to do kidney transplant for this type of a patient. Although, you know, literature report, you know, basically comparable results, but if you look at the results from European, like 80 units, I think they probably have more like a kidney graft loss compared to open surgery. But, you know, it's at the early stage, maybe some learning curve as well to contribute to that. Thank you.
I think that's a comment I would echo. If you look at the sort of a pan-European report, really spearheaded by the Barcelona group and a group in Ankara in Turkey, the graft thrombosis rate is about 2%, 2 to 3%. And, you know, these are all living donor kidneys. So I think, you know, we given our actually relatively small number of living donor kidneys in most centers, we would really struggle to accept that.
That's right.
All right. Well, with that, unless anyone else has got any comments, I might call the meeting to a close.
There was a couple of hands raised. I think Sam's
sorry.
got a little yellow hand, and I've got a little yellow hand.
Please. Sorry, gents. I'm running it from my phone, so I apologize.
Yeah. Sorry. Thanks, Jerome. Now, from what I've heard so far, I think in our Australian context, at least, the transplants for the class 2 and class 3 and the you know, those sort of obese groups are still being done open, and that is the current situation, except for 1 or 2 laparoscopic transplants that has happened. Now, as somebody mentioned, yes, we do have the option of sending these patients for bariatric transplants or some other weight reduction procedures, and then subsequently they come back for a paniclectomy and then go in for a transplant. So the way I've seen it in my unit here in Adelaide is that this whole process takes about 2 years for the patient to go on to the transplant list. And finally, they do have the transplant. With respect to whether they will develop any wound infection or not, maybe slightly more incidence, but then I see wound infection in patients with normal BMIs as well as the obese patients. We have done a little different take on this obese patients. We do not say no to an obese patient. We do class 2. Very rarely we do the class 3. Super obese don't come by. The obese patients, what we have been doing, one is initially we moved on to like the incision which was shown on the very first picture, the large incision away from the overhang or under the overhang, so that we could see the wound. The second thing that we tried was using the Traxi, retraction system, which the gynecologists use for their obese patients. We would put the patient in supine position, put the Traxi system on, and then go through an incision which is in the under the overhang, and which actually we have put that to good use, and we have not had an infection with that, I must say. So these are the two sort of things that we have tried. The other thing that we also do is selective draining of the renal bed. We do not put drains in all. And then, like Bulang said, we do put the subcutaneous drain if we find the patients are pretty big in the subcutaneous area. I sometimes prefer to take off the fat under the scarpas fascia. That loose fat sometimes comes in the way, and I feel sometimes it helps. So these are a couple of things that we have sort of played around in preventing wound infection. Another thing I noticed in the presentation was laparoscopic incisional hernia repair, which I wouldn't do it. I find it a bit risky doing a laparoscopic incisional hernia repair with a transplant underneath. Another option to prevent these things probably would be to taking off all that contents that goes into that inguinal canal, especially lipoma, the cord and stuff like that. And the kidney sort of behaves like an impediment for hernia to occur in that area. Sorry for taking time. I thought I'll just add that couple of opinions.
Hey, thanks, Santosh. It's a great bunch of tips for the obese patient. Henry, did you have something?
Yeah, it was just, I was just interested in the audience's experience of a hockey stick incision, because I don't think I've ever knowingly done one. And does anyone around Australia or New Zealand actually use such an incision? Because it doesn't, I mean, it's not statistically significant, but I think Sarah Sharastani's systematic review showed that hockey stick incisions had a higher incisional hernia rate. It was like 8.5% versus 5.6%, but it's neither here nor there, I suppose, statistically. But does anyone actually use such an incision or knowingly use such an incision? I use a Rutherford Morrison mainly because he trained in Edinburgh and worked in Newcastle, which is similar to me, so I couldn't use any other named incision. But does anyone use a hockey stick?
Yeah, Henry. I used to do that in pediatric population, the hockey stick incision. I was trained by an American surgeon, and we used it in many of our patients, many of our pediatric, in fact, all our pediatric patients, and most of the living donors back home in India. But that's only in the pediatric population I use, and I found cosmetically it looked pretty good too. But off late, I don't do that anymore.
Yeah. Not an adult, though, would you?
No.
Yeah, I totally agree on Santosh. That's the where we use hockey stick for pediatric, because basically, Henry, I see, on the proximal part, you extend towards almost to the coastal region with small kids like 8 kilos. That's where, hockey stick incision being utilized in that circumstances, not for adult, generally speaking.
Okay, no, I was just interested. I suspect you'll find there's lots of people around the world who use it routinely, but because they certainly publish on it.
Henry, I would, one comment I'd make is I often don't even know what incision I've made, because with all of these fat patients, you just cut somewhere, and then sometimes I cut muscle, sometimes it's a paramedian incision, sometimes I cut the rectus, sometimes I don't. Sometimes I'm too close to the middle of the rectus by mistake, and I just go through the through the midline and find the linear alba again. So I never really understood this very distinct classification of incisions. I think they're often, that's why it's probably hard to tease anything out from studies, because they probably all end up the same, or a mismatch of the same stuff.
I mean, I think
Can I just make a comment to go with what you said, Henry? And I think the reason that the hockey stick incision is such a poor one is that it de-innervates the rectus muscle. And that's the problem. And that's where you see the incisional hernias in patients who've had a hockey stick incision, is they have weakness medially because there's no rectus left, and it's because it's been de-innervated. And I think that's a really important factor in the incidence of incisional hernia in a transplant wound, because otherwise the transplant itself, the kidney itself, acts as a great mesh, and you shouldn't get a hernia there, even how poor the tissues are in obese patients. If you've done quite a transverse, almost oblique incision that doesn't involve de-innervating the only muscle they have, and that's the rectus muscle. That's my feeling anyway.
That's great.
Yeah.
Brian.
Thanks, Brian.
Good point, Brian. I love your accent, by the way, Brian. I was going to say, can I ask another question to the audience? Who does a two-layered closure? If you do just say a Rutherford Morrison or whatever, not a midline, but a Rutherford Morrison, whatever you want to call it, hockey stick. Who does a two-layered closure or a mass closure? Because I've sort of converted to a mass like 2 decades ago, I would say, but
I'm variable if they're fat, and I just can't do 2 layers. Then they get 1 layer.
okay.
I always do 2 layers, Henry. And what I do is the first layer is purely and simply a hemostatic on the internal muscle. And that's just to it's not really to add any strength, but it's for 2 reasons. One is to stop any bleeding from the cut muscle edge, which always recurs when you take your retractors out and you've finished your operation. Things that weren't bleeding because they were under retraction now start to bleed. So I just undersew that. The second reason for closing that, I feel, is to protect the peritoneum so that you never, ever pick up the peritoneum when you're closing with your second layer. And if you close that first muscle layer, I use a number 1 Vicryl and make sure the peritoneum doesn't get picked up. You get no bleeding from the muscle edge. I don't close it down medially at the rectus end. And then what we do is we actually put a rectus sheath catheter that comes from the lateral end of the wound between the closed internal muscles. Only external oblique needs to be closed, and that rectus sheath catheter sits in that little pocket, and then we close the external oblique as a second layer over the rectus sheath catheter, and we get really quite good analgesia for those patients, just putting in Marcaine post-operatively. But that's what I do, and I do it in 2 layers. Seems simple, and it works well.
Jerome, I also agree with your very, very honest comment. As you said, when you open, you don't really know where you open exactly. Somewhere more medial, sometimes more lateral. But basically, I thought you try to avoid too much lateral. You try to get what I thought. You try to get the superior part of the incision. You come across external oblique muscle layer. After that, oblique, that's fascia. Then on the medial part of the lower inferior incision will come across rectus muscle. What I do not divide the rectus muscle, just separate towards the end of just above pubic bone area, try to get a reasonable exposure rather than dividing. So that will give you good strength. I particularly close by 2 layers. But on the lower part of the inferior incision, basically is 1 layer tissue closing with the fascia, but I double close that part. On the superior part of the wound will be 2 layers. The further layer is external oblique muscular layer. Then on top will be oblique, that's fascia layer. So that's how I close. Generally, the 2 layers closure. And also on the medial side, when you try to dissect the actual peritoneal space, you try to create a little bit more space for your kidney, which potentially you talk about compartment syndrome. And also you get a little bit more edge from that incision. You give you good distance when you close better the muscle or better the oblique fascia as well. You give it reasonable space for you to bite without jeopardize the peritoneum or grab the bowel. That's where you get a bit of dissection when you first start the incision part. Yeah.
All right, everyone. Thanks so much. That's really wonderful set of comments. Sorry, did someone else have something? to add?
Yeah, Jerome, can I ask a question to the group? In the indigenous group, with respect to infection, is there anybody from Queensland? From what I, is there anybody who can appoint? Is there anybody on today from Queensland?
I can. I'm not from Queensland, but we have a large indigenous population from New Caledonia,
Okay.
and they have. You might have seen all those pictures that Tariq showed were from me, and all those patients are from New Caledonia, and those guys have about a 30% major wound complication rate, even at the same BMI. So, I guess it's probably a history of very poorly controlled diabetes. That's a major problem for them, and we never found a good way to fix it. Like, it was just intrinsic to that practice, I think.
Now, if anybody in the group had patients with fungal infections, what do you guys do? Do you keep
Do you mean
treating it?
Aspergillus or Candida?
Aspergillus.
Yeah, I've had Aspergillus infection of the abdominal wall and the iliacs, and that was not salvageable. That was from New Caledonia as well. I think those guys, they kind of hang out in caves or something. I'm not sure what they do, but it's obviously an environmental exposure that we don't see in the even the rural Caucasian population. You just don't see it.
So what is your, do you always take the kidneys out?
I think it's just fatal. I've never seen someone survive invasive Aspergillus, tissue Aspergillus infection.
Okay, we've had invasive Aspergillus, which I think they measure it as a couple of millimeters of infection that spreads into the skin and subcutaneous tissue, and the infection control said nothing must be done. But that's not what we did. We explanted the kidney, and I took this patient every second or third day to theater. And what I did was I actually impregnated topical antifungals into that wound using a spongy stand impregnated antifungals. And over a period of a couple of weeks, we were able to salvage this patient and send the patient back. He's alive. Anyway, it's a published thing in a journal. So we've had okay results with Aspergillus, but yes, kidney comes out, but we have been able to save the patient.
Well, that's incredible. I mean, I think, I've just been nihilistic about it, but I guess maybe if you find an infection which is relatively early, then that's I certainly wouldn't have. I would have done exactly what you did, and certainly support that approach. Anyway, I'm just conscious of everyone's evening ticking away. Thank you very much to Tariq for all his hard work putting it together, and all the trainees have benefited from a huge amount of experience from around the country and really great practical advice. So I think I'd just like to thank all the other surgeons who've taken up their evenings to come and give their comments and input. Thank you very much, everyone, and have a good night.
Thanks, Tariq. Thanks, everyone.
Jerome. Thanks, Tariq. Bye.
No, thank you.
See you soon.
Thank you.
Bye-bye.
Bye.